everyone, and welcome back to the Social Work Bubble podcast. I'm your host, Laura. I have my LMSW, and I currently work at a group practice in New York City. Today, we're getting familiar with what a day looks like for a therapist to hopefully provide some helpful insight to those that are trying to decide what feels like a good fit for them in the field of social work. Before we get started, remember to like, share, and follow the podcast on whatever platform you're listening on. Now, today we'll primarily be referencing my own experiences as a therapist in both outpatient mental health and a private group practice, both in New York. There's obviously many different settings that you can be a therapist in. There's clinical work in hospitals. You can work with those that are incarcerated. You can work with children in schools. Clinical social work is, I think, one of the more well-known parts of social work, one of the most popular, I would say. And so, you can be a clinical social worker in many different capacities as a therapist. For both experiences in both outpatient mental health and in private practice, you need to have a license or a temporary permit. This can vary. You need to have a temporary permit when you're practicing anyways, but there are many practices that are definitely open to hiring new graduates. I ended up staying on at my graduate level field placement and continued to work there as a therapist. And then about a little over a year and a half later, I then got a job at a private group practice. So we'll start with my outpatient experience, since that was the first clinical experience that I had. So in this position as a therapist, particularly in community mental health in an outpatient clinic, at this particular agency, having at least 30 weekly sessions is full-time, and this included usually a 45 to 60-minute session. Typically, in the outpatient clinic, I was scheduled for about 40 to 50 sessions a week, including a weekly parent support group that I led. I worked with a variety of clients. I worked with children all the way through older adults with basically any issue that they came in with. Because I was a new clinician, I had started off as an intern in that position before agreeing to stay on after graduation. It was definitely more like general practice in a way, where I would kind of just work with anyone about anything in order to get a good experience, which was really, really helpful for me because it allowed me to see what clients and what treatment modalities and what diagnoses I really gravitated towards and what things I could continue to hone my skill in. So it really allowed me to find a specialty that resonated for me and to work with a variety of individuals, which also, again, helped me understand what is it I want to do, where do I want to go from this. So in this particular place, I worked with people that had depression, anxiety, trauma, ADHD, BPD, parenting issues, substance use, incarceration, homelessness, who are involved in child protection, maybe some safety concerns. Many of the clients I worked with were high risk for either suicide or homicide. So there was a big variety of things that was going on because of the population that we served. Because in an outpatient mental health practice, this practice also accepted Medicaid, and they didn't have a cancellation fee. So we really served a lot of people that were in higher need or maybe needed more affordable mental health treatment. This also meant that we were dealing with a lot more, almost like crisis cases on a more regular basis. So when I first started off, and I noticed this when I transitioned to a private group practice, was I got a lot of experience in managing crises and doing a lot of crisis work and immediate work. But I didn't really get a lot of practice going into in-depth therapy and kind of doing that bigger psychodynamic piece. I was able to do it with a few clients, but generalizing my experience, a lot of it was high risk, looking for immediate resources, and doing a lot of crisis management and safety work. A big part of this role too was not just as a therapist, but as a case manager. I had a lot of collateral calls, which thankfully you could bill for, which is great. So you get paid for that time. Because something to keep in mind too is in this role and in the role that I have at the private practice, they're both fee-for-service positions. So when you see the term fee-for-service, if you're not familiar with that, it's basically what it says. You get paid based on the services that you provide. And the services you provide are what you bill for. So as a therapist, you really can only bill for therapy sessions or those collateral calls. So that's something to be mindful of, is how much work you're doing outside of what you're actually billing for. And I think that's what ended up eating up a lot of my time, where if I actually calculated the amount of hours I was putting into my work or the amount of hours I was scheduled to work versus the sessions that were actually attended and what I was getting paid, even though I think at that agency I was making $30 an hour, it almost felt like I was making minimum wage when you actually calculated how many hours I was working, and that I would only get paid based on if a client showed up for a session. That was one of the more frustrating parts. But we have to remember is, again, I think it's because of the setting, and I think this is why a lot of social workers and therapists end up burning out in outpatient mental health, but it's such a high need area, and outpatient mental health clinics can be so important and such a great place to work, especially if you have like good management and good support. But it was very difficult to have people consistently showing up to sessions for valid reasons. Like, they have a lot of things working against them. There was a lot of barriers to treatment for many of my clients, potentially like insurance changes. It was really hard. And as much as I can empathize with the experience of my clients and can see that there were certain barriers to treatment, I have to pay the bills. I also lived in an expensive city. So that was something to always take into consideration, is what makes sense, like what financial resources look like. Is there a cancellation policy at the particular clinic you're at? At this clinic, there wasn't. And so that was a big issue, is if a client just no-showed or they canceled last minute, I had that time scheduled off that could have been given to someone else that would have shown up. So that affected my money. And at the end of the day, what it made it feel like I was only making minimum wage for the number of hours I was working. Because like I said earlier, I was scheduled to work like 40 to 50 sessions a week, but I was probably, I don't even know how many people were attending. I would say maybe like, if I were to guess, like a 60% attendance rate, higher depending on the week. It honestly just depended. At the outpatient clinic as well, documentation was very different. And a big reason for this is the clinic was a nonprofit. They're funded by New York State grants and different funders through that. With that comes a lot of expectations and rules on documentation and paperwork. So a lot of the times you will find that outpatient clinics are a lot more heavy and intense in paperwork, and you have to be a lot more thorough and detailed in that paperwork. So that ended up eating up a lot of my time as well. I also just didn't really have a good baseline for what was acceptable, because at the same time, we were told to be detailed in our paperwork, but we also want to protect the client, especially clients that are already being over-policed and kind of overwatched in the system. You want to be mindful of what you're saying in a progress note and what you're diagnosing with them with, because that can also come back to bite them in court, with insurance companies, with a whole bunch of stuff. So you always want to be careful of that, but so documentation was pretty heavy. We had to review and redo treatment plans every 3 months with a client. We had to do daily progress notes, which was very normal. But it was also for any work that you did, you had to do a note on. So if I called a client, I would make a note of it. If I sent them a letter that they missed their session, I would make a note of it. If they called me, I would make a note of it. Even stuff like that. Just like very, 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 very detailed on really the contact that we were having. So that was that. I really honestly enjoyed my time in outpatient mental health with the work that I was doing. I formed really good relationships with my clients, and in many ways, I felt more fulfilled in that role, because of the population we were serving, because it felt like a higher need in the sense that there were just like more crises happening. There were people experiencing a vast array of like social justice issues and just systemic inequality issues, that it felt fulfilling in that way to be someone that was in their corner. So then I transitioned to a private group practice. For many reasons, I was burnt out. This job was higher pay. It was better hours. It was a better commute. Before, I was commuting an hour for work. With this, I only had to commute 15 minutes. So it was obviously like huge transition. At this private practice, it obviously differs based on what practice. Like private practices are for-profit businesses, and it depends on who owns them. If it's your own private practice, you still determine like what population you want to work with, what insurance you accept, what the cost of sessions is, if there's a cancellation fee, all of that stuff. So it depends on what practice you're at. With this, my experience in private practice was very different. There was more support from management because they were able to give the support. They had the energy. They also weren't burnt out because, again, they were not a nonprofit funded by particular grants, funded by New York State. There was less protocol. There was less unnecessary paperwork. There was, again, like better pay, better hours because clients had less barriers to treatment, and because a lot of the client population was from a higher income bracket, they were more consistent with sessions because they were able to be more consistent with sessions. They had more flexibility with their work hours. I still work with high risk clients, but they didn't have as many crises or stressors happening in their life that prevented them from continuing care. There was also a cancellation fee at this practice, so there's just the financial motivation to show up and be consistent, or at least give good notice. So that way I didn't have to schedule as many clients to buffer against cancellations, so that way I'm still bringing a pretty consistent paycheck home, where I can kind of determine how much I'm making, if that's enough, things like that. At a private practice, at this practice I'm at currently, we use Simple Practice, which I love. I think it's something I'm going to be using when I start my own practice eventually. The progress notes are shorter. They're more concise. The treatment plans are kind of updated as they're needed. We complete them once when we start with the client, and then if anything like drastic changes in treatment or their goals, then we can revisit it. But for the most part, again, and even that is way more concise and simple. Most of the collateral calls that I have to do are not very frequent. I think in the outpatient clinic job, I was doing multiple collateral calls a week. I was constantly emailing with other providers. It was part of the protocol to just always request medical records at the start of a client's treatment from their physician, which is important because we always want to rule out any medical concerns, or we want their medical history because that could be a huge factor in someone's mental health treatment. For example, I had a client I was working with that experienced auditory hallucinations, but there was no diagnosis of schizophrenia or anything like that, just experiencing these hallucinations. And she had a hard time remembering exactly why. And this was an older adult I was working with. I was able, with client's consent, to get access to her medical records from her physician. And there was a lengthy history there, again, because she was an older adult, but she had had an aneurysm, which had then caused the auditory hallucinations. Now that is a huge piece to treatment, is because when something is When a mental health thing is happening because of a medical issue, we're going to have a different approach to it. Like that's something that we have to be very mindful of. Exactly why some people that I work with now, if they notice that they are particularly depressed and that is very much in line with their menstrual cycle, that's something that we can collaborate with their doctor or their OBGYN on, especially with medication management or with birth control options. And that'll be a huge factor in their depression or anxiety. So that's always something to keep in mind. That was one of the more helpful things about all the protocol, was that we did get a very thorough history. But again, that's also something that if clients are willing and open to share that, you can kind of just get that from them. So again, in private practice, a lot of my collateral calls now are very few and far between. Recently, there's been an uptick just because I've been transitioning some clients to like a higher level of care. So I've been supporting them with just making sure that transition is going well and giving them relevant information to their new providers. There are some clients that I work with their psychiatrists. A lot of the clients at this practice, the owners of the practice have a relationship with psychiatrists or nurse practitioners, and so we refer our clients to them. And so we're already familiar with many of the psychiatrists that our clients work with. If there's an issue, if we feel like we can provide some insight to the psychiatrist or vice versa, then we have a collateral call. Some of my clients don't feel like that's necessary, and they just relay the psychiatry information to me. Unless I feel differently and I feel like it's important to have a one-on-one conversation with the psychiatrist or the doctor, like primary doctor, do I really insist on that or advocate for that? Again, still respecting the client's decision. But for the most part now, I have a collateral call with a psychiatrist or a fellow mental health professional if I'm referring them to treatment elsewhere. So, and again, it's few and far between. It's usually a phone call. I think in my previous job, there was constant emails and faxes and intense paperwork. Because again, a lot of the people I supported and that I was doing therapy with had services, some kind of government assistance, SNAP benefits. They were potentially involved in child protection work. So there was sometimes I'd have to send a letter to the court. At the private practice, I also work only with adults, and I was able to have a specialty. I only work with adults now because that's just the practice. They just don't work with kids, and that was fine with me. And off the jump, I was able to kind of specialize and begin working with clients that had particular concerns that I was better fit to treat, things like depression, anxiety, and trauma. Work outside of this is few and far between. The most I've done is write a summary for a client on the skills that we discuss. I do work with quite a few college students, and so if they need accommodations for something, then I offer some supportive documentation or a letterhead kind of situation, but nothing crazy. I might send a screening outside of a session to a client for them to complete, and we'll talk about it in a follow-up session. Right now, if a client is moving, I would gather a list of referrals near their home address or their area that they'll be moving to for continuing care. So at this point, as a therapist in this group practice, case management is not really a part of my experience other than the occasional collateral call I'll do to the psychiatrist or minimal paperwork I'll have to do for something that's going on. I really don't want this to color anyone's perspective on community mental health. It was a very valuable experience that allowed me to grow very quickly. I was able to find my voice as a therapist. I was able to really gain a lot of confidence and independence. And honestly, I felt like I was, like I said earlier, doing a lot more social justice work and making more of a tangible difference for people that had higher levels of need and multiple levels of need, more so than I'm doing right now. Again, I still work with clients that are high risk. I think I do very valuable work right now, but it's different. You know, at this point, I do work predominantly with people that have a higher income compared to the people I worked with before, and most of my clients are predominantly white. So it's tough because, especially in New York City, there is just, as a therapist who was burnt out, who also needed to just make financial ends meet, I think it was the right opportunity for me. But that does mean, and because I actually have the energy and the time outside of work, I do try to commit that time to doing more like social justice related work and volunteer work to kind of fill that need for myself, and also just to fill my ethical need as a social worker. Now, part of this podcast is also talking about finding balance, because I think being a therapist is really great, but it is hard because being a therapist it's really like a job like no other. You know, you are kind of in one-on-one meetings, if you're doing individual therapy at least. Just that's your whole job. And you have to show up for every single person and be so engaged and on top of it and very skillful. And there's a lot that goes into being a therapist, and it can be very stressful. How I find balance, I've learned a lot throughout my journey as a therapist to really determine what makes sense for me, what makes sense for my life, what my capacity is, what my energy level is. There's a therapist that I was working with, and she actually went down to be a part-time therapist, and then she took on another part-time job as a case manager. Just so that way it helped her prevent some burnout, because being a therapist and like having full-time therapy sessions in a whole week became a lot for her. So she still wanted to be a therapist, but she also wanted to like fulfill a different kind of social work role and skill that was different than just that direct one-on-one therapy session that was happening so much, because that's literally our whole job. That's something that you can always be mindful of, as you by no means have to be a full-time therapist, especially if your heart is in two different places. And I mean, there's so many different roles in social work. So you can always be a therapist on the side. There are many people that even have like a full-time job or part-time job, again, like in a case manager role or like at an agency, but then they have their own private practice or they work in a private practice on the side. So finding something that really feels like a good balance for you in that capacity. It's looked different for me because of the differences in the workplace. So based on where I worked, balance was different. But it was also because of my personal life differences. So throughout this time, I moved from living in New York City to living outside of New York City. That helped me sleep better. I had more living space. I felt more separated from the overstimulation and the stress of the city. I'm not a city person, so this was a choice that worked best for me, because I had lived in New York for 3 years and I just was not getting used to it. I was raised in the middle of nowhere, and so it was obviously a huge adjustment. And I realized, you know what, who says I have to do this? So I moved to New Jersey. I still live in a city, but it's obviously not as intense as New York. That was really critical to my balance and my self-care, was making those personal life changes that allowed me to show up in a different way at work. Because, I mean, when I lived in New York, I was living in a crummy New York apartment that was still expensive. I was renting 1 bedroom. I was living with 3 guy roommates that were all terrible and disgusting. And I mean, it was just very, very different. I was also right by the train. Living in the city was also, I was constantly anxious. I never really felt safe or at peace. You can never really get away from people or the noise. Even if you go to the park, it's not really like being outside, you know, or being in nature. So all those things I realized were really vital for my self-care and my downtime, especially as an introvert. And needing some time to actually have silence was important. A big thing I learned is also not to schedule sessions back to back. This is a lesson that I'm still trying to hold myself accountable to. I've noticed I feel more energized having even just 15 minutes between sessions. If I do have a back-to-back sessions, I try to limit it to only 2 to 3, and then I make sure I have a longer break before the next session. That's made a big difference. Sometimes it's hard for my brain to wrap around this idea like, oh, if I just do all my 45-minute sessions back to back, I only have to work like 5 hours instead of 7, but it's still 7 sessions, so sometimes I just get so stuck on this idea of like, oh, I only have to work this many hours, but it ends up just draining my energy and my ability to show up, which is not great. So always trying to be mindful of what your limit is in terms of back-to-back sessions. Again, this can also be influenced by the setting that you're in. If you have a high volume of clients, honestly, in outpatient mental health, I probably could have gotten away with scheduling my clients back-to-back because I had enough cancellations where I would have breaks anyways. But again, it becomes, you kind of figure it out with the nuance of the work setting, when you can kind of leave, everything like that. A huge thing is consistent supervision, and a working place where you feel safe to offer feedback on the agency. I think my outpatient mental health experience would be very different if there was different leadership and if I felt safe to complain and to advocate for myself and for the other people that were working there. There were some things that I think needed to change desperately. And even though I was already at like 40 to 50 sessions a week, I was still being pushed to take on more clients. And at that point, it's not safe. It's not safe for anybody. Like, that's how things are overlooked. It's a tried and true story that you hear of, like these horror stories of like overworked CPS workers, and then a child ends up dying. And it just felt like because of the need, they were pushing people to take on more versus just hiring more therapists and more employees. And in my outpatient clinic job, I did not have insurance. I did not have benefits. None of that. It was like a fee-for-service position. And so again, I don't want that. I don't want to paint that. I'm pretty sure it's individual to this particular place, but nonprofits, I think, because they have tighter budgets, because of, things that are relying on funding and fundraising, it is potentially harder, or they make you feel like it's harder to ask for raises or for better hours or for different things like that. But it is possible. And I think that's how, I think if you find a good nonprofit that has like good management, good leadership, particularly I think management and leadership that has been in that particular role themselves, so they kind of have that empathy piece to it, people can really thrive in that environment. A big piece, like any job, is just the culture. And if the culture is that workaholic, burn yourself out kind of place, it's not going to work no matter what setting it's in. That can happen in private practice, that can happen in outpatient clinic, it can happen in anywhere that you go in social work. So it's also just a matter of making sure you're asking the right questions, trying to get as much information as you can while you're in an interview or job search process. Finding balance for me also looked like having a reasonable commute time, a comfortable office space, both in the office and at home. And a huge thing that I've talked about before is being clear and consistent with my boundaries with clients. When I was fresh out of grad school and in the outpatient clinic, I feel like I very much had that superhero, almost like savior complex, where I was just like, okay, this whole place is just like therapists are leaving left and right. All these clients have been in and out of treatment and have just been cycled through therapists because their therapists are constantly leaving. I have to be that one therapist that just sticks around and helps them. Like, I'm going to be a part of their story where they can like reference back to me and be like, she changed my life. And I was kind of making it about myself, versus actually the care that clients needed. And because of that, I let my clients kind of boss me around. I didn't really have a lot of confidence when I first started. And I, again, wanted to just help everyone with no respect for my own boundaries. So that also fed into me working far too much and feeling really burnt out and at times even resentful of the work. So you always have to be mindful of your own boundaries, and to not push your boundaries regularly just to meet when a client is available. Because from what I've learned in my experience, if you set the tone for when you're available and clients want to be there, they will make it work. Unless it's like extreme circumstances. Flexibility I think is really important, but you set your hours as a therapist. And I think having a cancellation policy was also a big part of that. There's many times now that I'm still incredibly flexible with the cancellation policy. I really only do it if, I don't know, it depends so much on the situation, but even when clients are aware, if I know they're just in a financial hot spot, I won't apply the fee because I'm like, what am I doing? This is just adding to their burden. But a cancellation policy can be very helpful because it also sets the tones for clients to take treatment seriously and to show up and to respect the people that they are working with, like their therapists, and to respect their time, which is really important. I think this happens a lot in mental health, as we are not taken seriously like other health professionals. Like a client wouldn't treat going to their doctor this way for their annual physical, or if they need to pick up their, medications or something like that. But they can treat therapists that way, just like, oh, you're available when I want you to be available. And even though the clients are the boss and they're in charge, this is still our job in our life, and we have to make sure we're taking care of ourselves. So that's also how I have found balance as a therapist, is changing my own personal life situation and living situation, having a better commute, having a comfortable office space, work from home space, being mindful of my own scheduling and boundaries. And again, this can happen in both outpatient mental health and in private practice. And like I said earlier, there's so many other settings that you can be a therapist, a clinical social worker in. And it's just a matter of finding the population that you feel most akin to, what makes you feel the most fulfilled, or, whatever feels good for you. All right. Well, that wraps up our talk for today. Please let me know your thoughts and your own experiences as a therapist, what your day looks like. Don't forget to like, share, and follow the podcast. All the information and the resources we talked about are in the description. Thank you so much for listening, and we'll see you next time.